Welcome to the surfactant replacement lecture. So this one, we're going to cover some information just on surfactant replacements as it relates to neonatal replacement and sort of just the function of it. And some of it should be reviewed from when you guys were back in pulmonary A&P. So hopefully I'll sort of jog your memory a little bit there. And then we'll talk about how and why and if on the whole surfactant replacement procedure. Now, I do want to recommend, before you go through this too much, is to look at the AARC, the American Association for Respiratory Care's clinical practice guidelines on surfactant replacement therapy. You should know your CPGs for everything that it is available for in your practice. So please go and review those. Those will be helpful to you. And I will hope that we will set some of this up in lab as well. I expect you, when we do set up surfactant part of our lab for this course, that you'll be ready to go. You'll have the procedure sort of down and ready to go. You'll have the indications, you'll have the considerations, you'll have the procedure sort of ready and understood, and then just some basics about why we do it and what we do when we do. So please be ready. Please make sure you got that ready to go, and let's go ahead and get started. So why surfactant? Well, the big thing with surfactant is going to be we have an air-liquid interface, and it's going to reduce surface tension according to the alveolar size. So the idea here, and if this just sort of is a foreign language to you, right, just by looking at that sentence, you're like, you lost me already, okay? So the idea here is the alveolar surface, and I'll just do a purple alveoli because purple is awesome, and then I'll do capillary, just to make it complete. The idea here is that there's these little water molecules, and I'll use blue, little water molecules that naturally are inside your alveolar space. They're naturally in there. And surface tension, just like when you fill up a glass of water, right? Do a little experiment. Go and fill up a glass of water to the very lip of the glass. You can actually see water that actually goes above the lip of the glass but does not fall over the side of the glass. Well, what's keeping that water from falling over the side of the glass? Well, that's surface tension. And surface tension is basically water molecules, if they are in a group together, they'll want to stick together. They don't want to be separated. They are group people. They are extrinsic. They want to be out and about. They want to hang out in their groups. They're very cliquey. They want to stick together. And so when you have these water molecules that hang out on the inside of the alveoli, like we're drawing here, these water molecules will want to stick together. Well, what happens if these water molecules stick together? Well, that's going to pull the alveoli is actually going to be sucked in, right? It's actually going to suck the alveoli in because the water molecules will want to pull together, and it's actually going to pull at the alveolar surface itself. Remember, there's no cartilage in your respiratory zone. There's no cartilage in your alveoli. So that surface tension that's pulling the water molecules together will actually cause, an atelectatic alveoli, which is not great for gas exchange at all. Not good for oxygenation, not good for ventilation. And in fact, when those water molecules are sticking together and we have to overcome that surface tension for each breath, we're causing shearing trauma on the alveoli tissue. In other words, ripping this closed alveoli apart for each breath is just like Velcro, just tearing it apart and just tearing at tissue, because we have to use a lot of force to reopen and overcome that surface tension. So when we're doing this, we need to make sure that we have a surface that actually can reduce the surface tension, reduce the ability for water molecules to stick together. Well, what can we do that repels water molecules from each other? So just like the Scotch Guard that you can spray on clothes or furniture, right? There's something we can do that uses hydrophobic and hydrophilic parts to it that repel water molecules from each other, right? And that's the exact purpose of surfactant. It's to repel water molecules from each other. By repelling the water molecules from each other, we're allowing the water molecules to stay apart and therefore keeping more recruitment or keeping the shape of the alveoli open, right? So it makes it easier to get oxygen into the bloodstream, makes it easier for CO2 to get out of the bloodstream, and we avoid shearing, trauma, and bad stuff from happening, like inflammatory mediators from releasing. We avoid all these bad things by just making sure someone has an adequate amount of surfactant. Remember, the ability for water molecules to stick together is Laplace's law, and the whole idea with surfactant, we're going to try to nullify as much as possible Laplace's law. It's going to stop those water molecules from being attracted to each other. We're going to put something in between them, right? Leave room for Jesus, right? That's the whole old dancing thing, right? In between two partners. Hopefully some of you laughed at that. I don't know. But the idea is to separate those water molecules, avoid them from coming together, and that will help keep and maintain recruitment of the alveoli, keep space open in the alveoli, right? And that's going to have better oxygenation, better ventilation, and that's what this whole thing is about. We need to make sure that these babies, especially if they're premature, have the ability to breathe easily. In other words, they're not over here with this atelectasis situation where they're just closed down. We need to make sure, even if they're a term kid that was born with mature surfactant, let's say something happens and their surfactant gets nullified by a shunt. Let's say their PDA is open and then they had a massive amount of pulmonary edema. Well, pulmonary edema will dilute the surfactant that's in the alveoli and therefore cause atelectasis. So even though that kid is term, that kid could still need or be considered for surfactant replacement therapy, because now the surfactant that was in their lungs is no longer effective anymore. So we might need to give that kid surfactant replacement therapy if they have continuing hypoxemia and they meet all the parameters, right? We might need to give that kid surfactant, even though they were born term, right? Even though something like that happened, we might still have to do that. It's very common in your kids that have a left to right shunt. It's usually that PDA, patent ductus arteriosus. Where this happens, they'll get that pulmonary edema built up, because remember, with a PDA, there's more blood flow backing up into the pulmonary vasculature. Sort of like congestive heart failure. There's more blood flow backing up into the pulmonary vasculature, and that causes that edema, which then dilutes the surfactant in there. So we need to be very cognizant of this. If a kid's starting to have oxygenation ventilation issues and we get an x-ray and we see these things going on, this is something that we might need to consider, whether it's surfactant replacement therapy or increasing the mean airway pressure or increasing our positive end expiratory pressure, something like that. We all got to take into account each individual baby situation before we start just saying, everybody just go up on the mean airway pressure, or everyone just go up and surf everyone. No, there's risks and benefits to everything we do. We need to take that into account with every time we see this baby. So I know that's a long explanation, but I hope this first sentence makes sense. Why do we give surfactant? Why is it something we're concerned about? Well, there's an air-liquid interface, and we talked about the water in there, and this reduces surface tension, right? Surfactant reduces surface tension proportionally to the alveolar size. The smaller the alveoli is, the more it works, which is great, because then it has more resistance to collapse, to complete collapse, I should say. The bigger it is, the less resistance there is to it being effective, because that's also a protective mechanism. At the end of a deep breath, when the alveoli is super big and about ready to blow a hole in it, not a good deal, right? Those water molecules are going to be far apart from each other. And therefore, so are the surfactant molecules. Therefore, it has less ability to reduce surface tension the bigger the alveoli is. That's good, because then you'll have your stretch receptors kick in and say, hey, stop taking a deep breath or you're going to bust a hole in the alveoli. Exactly it. So this works good for both the end exhalation, where it's at its maximum potential at reducing surface tension, and it works worst on end inhalation when the alveoli are all the way full, where you don't want to overexpand. You don't want that surface tension. You want that surface tension to help keep control over the expansion a little bit there. So it's a push-pull relationship. At the end of inhalation, you want some of that surface tension there to help avoid the lungs from hyperexpanding. At the end of exhalation, you don't want as much surface tension there, because you don't want the alveoli to completely collapse. It's got to be this beautiful balance in between the two. So, surface tension is created by the attraction of water molecules to each other. Hopefully this stuff, you'll be like, okay, now I get this, right? We're trying to reduce that water molecule from attracting each other. So during breathing, your CO2, and hopefully you guys remember this from way back in chemistry class, when you breathe, CO2 and water are exhaled at the surface or are transferred at the surface of the alveoli. That water is a part of respiration, external respiration, if you remember right, and that creates water molecules or water droplets to sort of form in your alveoli. Well, this is what then creates that liquid interface with the inhaled gas. It's not necessarily blood unless you have a pulmonary edema or diffuse alveolar hemorrhage or something like that. It is usually just regular water, sterile water. Well, human water, I guess it should be. This is composed of 90% lipids. So when we're looking at surfactant, it's composed of 90% lipids, and most of it's going to be what's called phospholipids. And then there's a little bit of protein in there too. The lipids really help make it so it does reduce that surface tension altogether. Right? PC is the most abundant phospholipid, and we'll talk about this more in detail, especially during this lecture, and then as we get into some of the other lectures when we talk about how do we know if a baby's lungs are mature before delivery, and why is that important. That's going to become an important thing to look at here, is looking at the PC level. All right, continuing on, surface tension is reduced in proportion to the number of surfactant molecules per surface area. So that's what I was saying before. It displaces the water and lowers the surface tension from 75 dynes per centimeter to 25 dynes per centimeter. That's a big difference, right? 25 dynes per centimeter is a lot less stress to overcome for each breath. That's why if a baby, let's just say they have meconium aspiration syndrome, where some of the fetal bowel movement, the contents of the fetal bowel got into their lungs, it can actually take the surfactant that's in their lungs and make it so it doesn't work. It's not effective surfactant anymore. And so now that whenever that baby takes each breath, they have to overcome 75 dynes per centimeter. That's a lot of force to take a breath. Well, this means the baby's not only going to have to breathe harder to get a deep breath, but they're going to have to breathe faster. And also you're going to have to factor in now blood sugar. Blood sugar is a big thing. If a kid doesn't have the energy to breathe, they won't breathe, right? Especially if they're premature, they won't have enough body fat. That's called brown fat. They won't have enough energy to breathe. That brown fat's used for energy to breathe. So that's when you see a kid retracting, when you see a kid working hard to breathe, you see him nasal flaring, you hear him doing expiratory grunting. We called it singing, right? Is our fancy term. Like, hey, do you hear that kid singing? Yes, I hear the kid singing, which is a fancy word for the kids grunting to help maintain PEEP. They're grunting to help maintain some sort of positive end expiratory pressure on themselves. And so when we see that, that might be a sign a kid might need surfactant replacement, or maybe the kid has a pulmonary edema, or maybe the kid has some fetal lung fluid that's hanging out, right? That's called TTN, transient tachypnea of the newborn or neonate. So when we're looking at this, that's a big difference. When you see a kid grunting, working hard to breathe, all those things, one of the things that could be causing this is something that's either diluting or the prematurity where they don't have effective surfactant at this time. So hopefully you understand that surfactant not only decreases surface tension, but at low lung volumes, it actually counteracts decreasing alveolar size. In other words, when the baby exhales, right? So let's go a full-blown alveoli here, and then let's say your alveoli here is smaller on exhalation, so I'll put inhale and exhale, right? So on exhalation, your alveoli is a lot smaller. The idea here is that when you do this, when a baby has lower lung volumes, especially like I say here at exhalation, or maybe they have something pushing up on their stomach, for their stomachs pushing up, they just had a large amount of tube feeds, right? Something like that's pushing up against them, that decreases their alveolar size, that's restricting their size. That's when not only does it reduce surface tension so they could still breathe easier, but it also helps the alveoli from continuing to collapse all the way for atelectasis. In other words, it maintains lung recruitment. It maintains lung recruitment. It maintains alveolar size even at low volumes, which is great. That will help avoid lung trauma, right? That shearing trauma of a collapsed atelectatic alveoli ripping open like Velcro every breath they take. It's going to cause inflammatory response. It's going to cause some other stuff to happen. We don't want that. This is the good picture. This is directly out of your material. So on inhalation, you see the large size, letter A on the top here, the large size of the alveoli, and you see that the molecules are spread far apart. But as we exhale, as we go over here, as we exhale, the molecules become closer together. Therefore, there's more surface tension on exhalation than there is on inhalation, right? So the more distance we keep between these, the better. So when you look down here, and this is without surfactant, when you look at letter C down here, this is a fully inflated alveoli. Alveoli has surface tension that's sort of there, but it's not bad. It's keeping those molecules far apart. And then as we exhale, notice that the surfactant, which is the squiggly lines here, these squiggly lines, right, in between these molecules, the squiggly lines help act as a spring to keep the water molecules apart. Therefore, on exhalation, we have a larger alveoli than we do without surfactant, right? So with surfactant, bigger alveolar size, maintaining lung recruitment. If we don't have it, like we see up here with the letter B, right? Look at letter B and letter D right now. Letter D, as in dog, has larger size, larger surface area, better ability to get oxygen in and CO2 out, less collapse, less ability for lung trauma. When we look at letter B, smaller size, now we're going to have to overcome much more pressure for the next breath, more prone to collapse, more prone to having lung injury. So this surfactant really does help repel these molecules and maintain lung recruitment, especially at low volumes, and this is the example. Continuing on, surfactant increases lung compliance. Remember, the lung compliance is the ability for your lungs to accept volume, or how stretchy your lungs are. Now, this can go to an extreme if we lose elasticity, of course, like you see with emphysema. That's not what we're looking at here. Here with neonates, their lung compliance tends to be a little bit lower, right? And so this allows for the residual volume of gas, so the end exhalation, as far out as they can possibly go, to be evenly distributed. In other words, instead of having an alveoli over here that's open and alveoli over here that's closed, and let's say they're connected, right? Instead of having that happen, it's going to allow for a lot more alveoli to be open at the same time. Right, it's going to have a lot more of those clusters maintain opening. Now, hopefully you guys remember seeing some of my old videos on alveolar recruitment. If you can look those up, and I'll probably try to post some links to them if I can as well. So you can actually watch those little alveoli. You can see how some of them will open up and some of them won't. Some of them will stay closed down like you see here. Now, this is not our goal, because when we usually do these type of things, if I try to open up this little alveoli over here and the rest of them are open, path of least resistance is how gas flows. So if I increase PEEP, if I increase mean airway pressure, if I increase peak airway pressure, if I increase PIP, if I increase anything, the gas flow will go to these areas that are already open and hyper-expand those areas, and then cause possible hyperinflation injury on those areas. Will that gas flow go to that little shrunken down alveoli? Probably not. So what would be a safer way to do this if I have areas that are open and areas that are completely collapsed? Hey, surfactant. That sounds like a great idea. So instead of giving a kid more pressure, whether it's mean airway pressure, PEEP, IPAP, peak airway pressure, instead of giving them more pressure on our breathing machine, they might consider, or we might consider as a healthcare team, to go ahead and provide surfactant replacement therapy, and it may help recruit lung tissue without ever having to change any of our settings, and therefore help oxygenation, help ventilation, and avoid overinflation, and avoid some of those troubles that we have with higher pressures. Not only that, but with higher pressures, you can impede what's called venous return with the vena cava, especially on a baby, and really affect their cardiac output, right? So this is a whole can of worms when you start talking about, hey, let's just increase pressure, whether it's a neonate that's 2 minutes old or an adult that's 92 years old. Just increasing pressure, you got to be careful of that vena cava getting crushed with mean airway pressure. You got to be careful because that could really affect their hemodynamics. And hemodynamics are a big deal even in the neonate population. So if you have a kid that was a cord separated in utero or low blood volume kid and we're trying to ventilate them appropriately, just going up on pressure may actually do this kid more harm than good, right? That's where we might have to think, what are the thoughts on giving this kid surfactant? Are they stable enough for surfactant replacement therapy, right? These are all thoughts that we'll start talking about here. So it helps even out the distribution of gas. There's the bullet point number 1. The absence of surfactant, distribution of ventilation becomes uneven, and that's where we get this sort of situation up here, where one area is allostatic, the other area is open and if not hyperinflated, right? And the lungs can then become stiff and allostatic, and then especially on exhalation, where we have this whole area just closed down over here on exhalation, and it takes a lot of fresh pressure and force to get that to open, which may not eventually be exerted on it. So I wish I could give you guys my lecture on lung recruitment maneuvers, but that's a whole separate course, unfortunately. But when we're looking at this, surfactant, if it's deactivated, if it's diluted, if it's not mature, can really cause a lot of struggles with the stabilization of our baby, with getting oxygenation and ventilation taken care of with our baby. So the baby's going to work hard to breathe. They're going to develop hypoxia and then respiratory failure. Here's the thing with neonates. The sign of cyanosis is the last thing you will see before they go downhill. If you see a kid that is cyanotic, pale, dusky gray, sort of that grayish purple, right? You'll know it when you see it. Trust me, you'll know it when you see it. It's the last sign. These kids compensate, crash. These kids don't just generally have a slow, steady decline in their health status and a slow, steady incline. They are compensators until their body can no longer compensate, and then they shut down. It's very unfortunate. So if you see hypoxia, it is a late, grave sign in neonate pediatric care, right? It's a late grave sign in neonate pediatric care. So we got to look for signs of respiratory distress before hopefully they get there, right? If you see hypoxia, something's been going on for a while and now they crashed, right? So hopefully before then you're paying attention to how they're breathing. Are they using accessory muscles? Are they retracting? Are they nasal flaring, right? Are they bobbing their head, right? You'll see that in your literature as well. Head bobbing is a big thing to pay attention to. A lot of people, when I would orient them, they wouldn't understand it. They wouldn't see it. And I'm like, if you see a kid bobbing his head like he's shaking yes or no, and there's good examples of it in your text, that's a sign. That's a sign that kid's working hard to breathe. It's not going to look like an adult's, right? They have their own ways of showing you they're working hard to breathe. Become masters at that. The earlier you could identify work of breathing on a neonate pediatric patient, the better neonate pediatric therapist you will become, because you'll be able to get those things early and provide interventions or discuss with the care team earlier on before this kid has a more life-threatening episode, right? Our whole point is to avoid that whole episode, right? So this is why I want you guys not only to look in the chapters, but also make sure you're being a student of what we're doing, why we're out there, right? Look for those signs of work of breathing and respiratory distress in pediatric patients. Look for those. Be active at learning, especially once you're done with this course. Be active. And that's the other thing with this course. When you guys are out there, make sure, especially if you work at a place that doesn't have a neonatal ICU or pediatric ICU, this information becomes even more valuable to you because then you don't have that resource readily available to you. And so I challenge you, especially if you don't ever want to work with neonates or pediatrics, then I challenge you to get the most that you can out of this course and out of your clinical rotations, because that's going to be much more important that you understand this, because you might be the only person that has this underlying baseline knowledge of what respiratory distress looks like on a kid. You might be the expert eyes in the room, so I challenge you, whether you work in a pediatric hospital or not, to become a student of this, to continue to learn past this, especially if you work at a place that doesn't have labor and delivery or a pediatric unit. All right, in short, these are taken directly from your book. Surfactant prevents lung collapse when you're exhaling. We've already gone over that. It decreases work of breathing, which means they're not going to consume as much oxygen. Their VO2, remember the VO2 is oxygen consumption. So that means their FiO2 requirements are lower. That means their work of breathing is lower. That means they're not having to burn up as much blood glucose either, right? It optimizes gas exchange. The VQ ratio improves. In other words, we don't have to provide them as much pressure with our ventilating machines. We don't have to provide them as much PEEP with our CPAP with our CPAP machines. We don't have to give them as much support, whether it's FiO2 and or pressure, to help them breathe. It will help their lung compliance, right? This is going to make it easier for them to breathe without causing lung trauma. It protects the epithelium. And remember, surfactant is even present on sputum. Right? When someone coughs or spits up something, it's even present there. It helps with airway clearance therapy. I'll say that again. It helps with airway clearance therapy. Now, here's something I need you to pay attention to here, okay? And this is something you need to remember when you're giving surfactant replacement therapy. This can dislodge a mucus plug, and it's happened to me, right? We've given surfactant, and surfactant actually helps move and facilitate foreign material, whether it's dust or whatever. It helps facilitate mucus or whatever it is to move and to mobilize. We're lubricating the inside of the airway, so it helps it mobilize. So you need to be prepared that there could be a mucus plug that moves after you give surfactant, or even during. In our case, it was during surfactant delivery. And while we were giving surfactant to this baby, a giant plug came up, clogged off the ET tube, right? It's a big thing. You just got to be prepared for this. And then you got to have a plan. If that happens, what am I going to do? What is the plan, right? So you need to be prepared for those. So don't look over that point, right? It helps with airway clearance as well. Prevents capillary leakage of the fluid into the alveoli by reducing surface tension. It's actually going to cause a less vacuumous space. I hope I said that right. It's going to cause less negative pressure. It's going to cause less vacuumous space to actually pull blood from a capillary into the alveoli. The smaller the alveoli is, the more negative pressure that we have to generate to pull that alveoli open. It's going to cause, remember, we're trying to use negative pressure to breathe. We're going to have to increase our negative pressure, and the more negative pressure we do can actually pull blood from the capillary into the alveoli. Where if the alveoli, and I'll draw another one here, if the alveoli was already fully open or stayed at a good volume, we don't have to have near as much negative pressure to take that breath, and therefore there's less going to be pulled from the capillary into the alveoli. In other words, it'll reduce pulmonary edema, right? It's going to reduce pulmonary edema. So it's going to reduce that altogether. The other thing too, it'll help defend against microorganisms altogether. So that's the big thing there. It helps with infection too, because it helps with airway clearance as well. That's part of your protection mechanism. So it's going to help clear all those things out. All right, how do we know if the lungs are mature? I love that picture of the rock doing the pager thing. Measurement of phospholipids in the amniotic fluid is used to look at the fetal lung maturity. So we can actually look at fetal lung maturity before the baby is born. And this is going to be a big help to you if you work in neonates, if you work with neonates, if you go to high-risk deliveries. This is something that you want to be aware of, right? We're going to look at something called PG. I'm not going to try to pronounce the whole name, but PG and lecithin increase during gestation. So the more PG or lecithin there is, the more mature their lungs are during this. Now remember, we can do things during gestation, during while the baby is still in mom, to help develop the fetal lungs. If the baby doesn't come early, that's okay. Even though we gave the mom the steroids, or even though we gave the mom the medicine that helps the lungs mature, no harm, no foul. So if there's a question that that kid could come early, we'll probably give them steroids as of recording this, right, until things change. But as we're looking at this, the sphingomyelin decreases during gestation. So the higher the lecithin, the more mature, or the higher this S word, sphingomyelin, the less mature, right, the lungs are. So we're going to look at what's called the LS ratio, lecithin to sphingomyelin ratio. We just call it the LS ratio. All right, if we have a higher lecithin, which is maturity to the S word, whatever, then that's, if we have higher LS ratio, that means we have more mature lungs. A lower LS ratio, and we'll go over examples here, the less mature the lungs are, and the more we have to be prepared to possibly give surfactant at delivery or respiratory distress at delivery, so on and so forth. So we could look at this ratio for lung maturity. I'm getting ahead of myself here. PG measurement is considered to be more accurate than LS ratio. So while you're out there, this is something that I learned in school, was the LS ratio. They did it a couple of times. However, they're more commonly to do the PG measurement than the LS ratio. Just from my personal observation, your hospitals that you may do clinicals and or work at might be different, right? It's all up to the perinatologist, the OBGYNs, the neonatologist, all those businesses come to, all those parts come together to help consider what's the best situation here. PG can be used in amniotic fluid. If we get amniotic centesis, right, we get a sample of the amniotic fluid there. Or if let's say the water's broken, let's say it's a premature rupture of membranes and the water's broken, but there's a vaginal pool, we can still get a sample from the vaginal pool on infants that's premature rupture of membranes. So PROM, premature rupture of membranes. So whenever you hear me in other lectures say a PROM mom, that's what I mean, a premature rupture of membranes, right? There's nothing else behind that, just a PROM mom is premature rupture of membranes, so that baby's more prone to usually infection because the sac around them that's usually protecting them is also is not there anymore. It's not intact anymore, so now they're more exposed to infection and things like that. So we can still, even though the water's been broken, right, premature rupture of membranes, if there's a vaginal pool of the fluid, then we can still sample the fluid and see if the kid's lungs are mature. If they're not mature, they may want to keep the baby in. If they're not mature, they want to keep the baby in. If they're mature, then if the kid comes or they induce labor, we don't have to worry about as much intervention there, right? It helps us prepare, right? So knowing that helps us prepare. So how do we assess lung maturity? There are 3 things to do it. There's the LS ratio, the shake test, which I just put in here because it's more historical. I haven't ever seen it used in my practice, but that's just saying that's my one data point is my practice, okay? So you might see it otherwise out there. And then the PG, which is the most common one that I've seen out there. So I've seen LS and PG out there, never seen shake test, but we'll cover all 3 just so that way you're well aware of the different ways to look at it. Okay, LS ratio is the first one. Lecithin, remember, this is the stuff that becomes greater in quantity the more mature the lungs are. The S word, the sphingomyelin, becomes less in quantity as the lungs mature. So the higher the L and the lower the less, the more mature the lungs they are. The higher the S, the lower the L, the more premature those lungs are or immature those lungs are, right? So those are something that we can sample, right? And see from either an amniotic centesis or a pool what we're expecting with the baby's lung maturity. Remember, why do we care about the baby's lung maturity? Well, what's the first organ to form is the heart. In the baby, the last thing to form and the first thing that's needed is the lungs, right? And that's the first thing they need. Once you establish, if a baby comes out and nothing else is going on, like they weren't a massive blood transfusion loss or anything like that, and you're doing NRP or neonatal resuscitation on a baby, and something's going on there, the first thing you should establish is an airway, a patent airway, and ventilation. I will tell you from personal experience, most of your NRPs, if you get the baby intubated, if you get ventilating airways, is usually when the heart comes around. That's usually when we get the heartbeat. That's when we get everything else coming around. That's a key point, that breath, getting that breath into them, and then everything else comes out. Remember, in baby world, it really is ABC of CPR, airway, breathing, circulation, right? In the adult world, usually it's cardiac arrest that's the issue. Pediatric world, it's respiratory arrest that's an issue, or respiratory difficulty that's an issue, right? So usually either mucus for a pediatric patient, or for a neonate, they're not breathing yet, we need to get them breathing. Most of the time the heart comes around after that. Adults, it's not usually breathing, usually it's the heart, so we need to get the heart beating, right? We need to start perfusing. Once we start perfusing, that's usually when things can come back around. So it's very important that you understand, do we have mature lungs or immature lungs, especially if we're going to try to resuscitate a kid. So the Ellis ratio, it's tested either in amniotic centesis, and you guys can look up exactly what that is, but they just sample that lung, the amniotic fluid while it's intact, or we can do it from a premature rupture of membranes, a prom from a vaginal pool, or even if the kid's born in the delivery room, we can just suck the stuff out of their stomach, right? We can get a gastric aspirate, right? So this would not be something you would traditionally do. That would be either the NMP or one of the other members of the care team that's supposed to go gastric with their materials, and then they would just get a sample there, and we send it, and we can get an LS ratio from it as well. So then we can sort of see what we're expecting, if we should hold off on giving surf, or if we should consider surfactant replacement therapy, so on and so forth. All right, so what does it mean? So 2 to 1 means they're more mature lungs, right? This baby is less likely to need surfactant replacement therapy. Doesn't mean that they won't require it. It just means that they're less likely to need it because their surfactant is mature, right? There's still things that can deactivate it, like meconium and pulmonary edema, things like that. But when we see a 2 to 1 or greater, then that means, we're expecting good things as far as the lung maturity goes. If it's 1.5 to 1.9 to 1, right, means they're transitioning. This would be more of your late pretermers. You're like 35 to 36.9 weeks in that area. This kid's transitioning to mature surfactant. All right, so those babies, they might need like a little bit of CPAP, they might need a little bit of support, but overall, these ones are usually going to do pretty well. They might need some surfactant, but overall, they're usually pretty low maintenance when it comes to their respiratory needs. If it's more of a 1.4 to 1, it should be 1.4, right? There shouldn't be this little extra dot there. It should be 1.4 to 1. They're immature, and these babies are more prone to need surfactant replacement therapy. And we're getting into the preterm kids here when we're going at 1.4 to 1 or less. And these kids are more likely to probably get surfactant replacement therapy at delivery. And we'll talk about that, whether or not some facilities may do that, some may not. And we'll talk about benefits and risks associated with that there. If it's a 1 to 1 or less, that usually indicates severe lung maturity. So in this area, we're looking at roughly probably a 28 weeker or less, right? My oldest daughter was a 25 weeker, and of course, her lungs were not mature no matter, and we had some steroids on board. Lungs were obviously not mature, so these are going to be the cases where surfactant replacement therapy might be delivered in the delivery room as long as the baby's stable. An important thing to remember with this is the patient has to be stable. Baby's got to be stable to deliver surfactant. So you cannot have a baby that has a very poor heart rate, very poor tone, very poor APGAR score. If you haven't gone over the APGAR score yet, please go look at that real quick, and we'll talk about that in some of the other lectures as well. But if a baby has a very poor APGAR, the baby is looking very, very unstable, we're not going to give surfactant. Because what are you doing with surfactant? You're putting this pretty much milky white substance down into their airway, and even though it's going to help compliance, it's going to help ventilation, it's going to help oxygenation, the procedure itself could still cause the patient to become unstable and vagal, and all this other stuff could happen with it. So there's more risks than there is benefits currently, as of recording this, to giving surfactant to an unstable child. So as long as the baby is stable, let's say they have an APGAR of 8, right? That's considered more of a stable baby, and that's when we might go ahead and consider to give surfactant replacement therapy if it is needed, if we know that their lungs are mature. But yeah, the lower the LS ratio, right, the closer to 1-to-1 that we get, if that's all you remember, the more mature they are and the more likely they are to need respiratory support, especially lung protective respiratory support. Just like adults, that's why we have things like the oscillator that use very low volumes and high respiratory rate. Sounds a lot like ARDS net ventilation, where we go down to ultimately 4 mLs per kilo, right? Same thing here. We go to very, very small tidal volumes and very high respiratory rates because we want to avoid that overdistension. We want to avoid volume trauma on those lungs. The shake test, this is in here just more for fun and completeness. This is where we just take a sample of the amniotic fluid, we mix it with alcohol, and then you shake it, right? Should be, if the surfactant is mature, bubbles will form at the surface within 15 minutes. This is a very informal test, very subjective. I see bubbles. No, I don't see bubbles. Well, I see bubbles. Well, I don't see bubbles, right? Forms at the surface within 15 minutes. It's not considered the most scientific test, but if there's no surfactant, mature surfactant, I should say, it will not bubble. Surfactant will bubble because remember, it reduces surface tension. So if it bubbles, hey, it's mature because it's reducing surface tension. If it does not bubble, then it is not mature. Like I said, there's more subjectivity to this one, and that's what we're seeing here. PG, this is the one I've seen most commonly out there. This is the level of that mature phospholipid. There's the whole word there. All right, have fun pronouncing that. Enjoy it. Measured from aspirated amniotic fluid. So that would be an amniotic centesis, right? There we could also get it from a vaginal pool, or I believe this one we can also get it from their stomach as well, like what we were talking about with the LS ratio, from a gastric aspirate from the baby as well. It's produced by, hey, guess what? Your type 2 pneumocytes. Remember that produce surfactant. It's unable to detect until the 35 weeks. And once you get to 35 weeks, those are more of your late pretermers. So anywhere between 35 and 36.6 is going to be considered what we call a late pretermer. And those late pretermers, they have usually issues like blood sugar, a little bit of respiratory issues like just tachypnea. Usually they'll be fine. And then temperature control, blood sugar, temperature control, tachypnea, and then a little bit of feeding issues sometimes, like latching, things like that. Not a lot of issues. They do need to be watched, but they're not term kids by any means. So sometimes you will have to put those babies on CPAP for like 24 hours, or you have to put them on some sort of airway pressure for a while, just to help overcome their work of breathing if they just sort of need to mature a little bit. But PG, not usually detectable beneficial until their lungs are roughly around 35 weeks of gestation. Now, let me ask you this. If we'd given mom steroids at 25 weeks because we thought the baby was coming early, and then now the mom's at 34 weeks and we see PG in there, well, that's probably because the steroids help mature the lungs a little bit, and that's what we're seeing in there. That's a good sign. That's going to help you. If you see that a baby's level of PG is there and they're at 34 weeks, hey, celebrate, right? Give yourself a Snickers bar. Whatever it is, celebrate. When we're looking at surfactant dysfunction, I thought this chart was helpful in your book. Do I expect you to memorize this? No. What I expect you to do by looking at this is see how all these things can fall into surfactant dysfunction and why surfactant replacement therapy might be beneficial for a lot of different types of patients. So when we're looking at a baby that has lung injury, and we call it RDS, respiratory distress syndrome, for a baby, we don't call it acute respiratory distress, we call it RDS, respiratory distress syndrome. There's a lot of similarities here, right? And we'll go over that more in our disease presentation. But when we're looking at a baby having inflammation, so let's say a baby got hyperinflated or a baby had aspirated meconium, right? That fetal bowel contents, right? That can cause a lot of depletion, microphage activation, which causes your inflammatory mediators and oxidants and proteases. These are all released with ARDS, right? So same thing with RDS. They're all released. That then leads to surfactant dysfunction, which means their FRC is going to be low, their compliance is going to be low, and they're going to be shunting more oxygen. In other words, they're going to have less oxygen go to their tissues, more likelihood of hypoxemia, therefore more likelihood of not getting enough oxygen to things like the brain, the kidneys, so on and so forth, the heart. Right, type 2 pneumocytes, this is more your premature kids, right? Obviously their surfactant is altered, and so obviously their surfactant is dysfunction because it's not altered, it's just premature. Therefore they're going to have low lung volume, so they're going to be very allostatic and white out on their x-rays. Very poor lung compliance. We're going to have to use high mean airway pressures for them. They're going to have high FiO2s, right? That's what the whole shunt thing comes into place. Higher FiO2s. Remember, this, if it's atelectasis from surfactant dysfunction of some sort, that's considered a shunt-like effect, but it's also a capillary shunt, so it has some true shunt capabilities as well. You know, how clear was that point? So in other words, we will be able to help reverse some of the hypoxemia with recruiting tissue. However, until we have the tissue fully recruited, or with FiO2, until we recruit the tissue, it can still act like a true shunt in some aspects. Alveolar metabolism of surfactant, this is where we have an aggregate that forms, causes dysfunction, therefore the low FRC, and then finally the AC membrane integrity, especially if we're having a pulmonary edema, increased permeability. There it is. That pulmonary edema, which I already talked about, decreases surfactant effectiveness and therefore causes the issues. So you got to be careful with this. A lot of things can cause a patient to need surfactant replacement therapy. So if you understand if there's inflammation or prematurity or something that's causing a metabolism issue, or the kid has a left to right shunt going on, like a PDA, then all those things, if you're aware of those 4 situations and you see, hey, we're having to use higher FiO2s, or their tidal volumes are smaller, or their pressures are higher, right, just to maintain it, and their x-rays are more whited out, those are all signs that you might want to consider. Hey, what are the thoughts with the care team, right? This is where you talk with the care team. What are the thoughts on surfactant? What are the thoughts on our strategy with this baby? All right, so what can we do to accelerate surfactant? Well, surfactant production is naturally accelerated. Mom can actually accelerate it naturally. I don't recommend this, but some of these moms that use certain drugs out there could actually cause it to metabolize and to cause that. Now, some of this is a stress response on baby, right? So anything that stresses mom out, in a situation is actually a protective mechanism that the body says, hey, that releases those stress hormones and the stress responses, the cortisol release, all that stuff naturally will then go through the placental barrier, just like we looked at in the womb video. A lot of that stuff can cross over, and it actually can cause the baby to develop and accelerate the baby's development if mom's under stress, and that's a survival mechanism, right? It's pretty cool. Maternal diabetes absolutely can accelerate it as well. So if a baby or a mom has gestational diabetes or non-gestational diabetes, those babies actually might have more mature surfactant earlier on. And then we'll talk about those babies possibly being LGA, large for gestational age as well, which can cause issues with delivery, especially if the hips are too narrow for the baby's head, and because the baby's bigger, right, and large for gestational age baby. So those kids are more prone to C-sections, which are more prone to not retaining fetal lung fluid because they don't get that vaginal squeeze, right? A lot of this stuff we'll go into, and we'll go into those. Maternal hypertension, once again, that's a stress response by mom that will help the baby go out. Premature rupture of membrane, once again, that's a stress response. Baby will hopefully try to increase their mature surfactant there. Maternal infection, once again, stress response. And then finally, abrupto placentae. This is where the placenta actually abrupts, and it can be a bleed. We can have partial abruption where there's just part of the placenta that detached, or the whole placenta attached, which a complete abruption is not a good thing at all. Not a good thing at all. And you might have to remember to give fluids. And remember, whenever you're giving fluids to a baby, it's 10 ml per kilo is what you're doing. So if a baby's cord is detached or a complete abruption is there, you think that kid's 3 kilos, that's 30 ml, right? If that's something I want you to have down, I will test you on resuscitation, neonatal resuscitation, right? I will test you on that. I want you guys to be able to know resuscitation on a baby big time. You will thank me for that later when we're looking at it down the road. So abrupto placentae could either be partial or full. This would be sort of in the terms of a partial abruption. That would be a survival and a stress response mechanism as well. When we're looking at artificially increasing it, we can increase it by giving steroids to mom. So there's 2 steroids. There's betamethasone, which is the more common one, and then Decadron or dexamethasone, which is the other one. There is one that's preferred over the other. You'll see that in the notes on the PowerPoint presentation, but they'll use one or the other, just sort of depends on supply and if it's available. But overall, giving mom the steroid shots, and hopefully at least 2 shots is the plan, and having at least 24, 48 hours, if not 72. I mean, the longer it's in her system, the better for baby. But that's going to at least help accelerate the lung maturity before that baby comes out, which means your job as the delivery staff or as the NICU staff therapist is going to be a lot easier. You're looking at a lot better compliance, a lot less hypoxemia, a lot less FI2 issues, a lot less pressure issues, so many things. So if we think a mom is going into premature labor, yes, we may, depending on the situation, we may try to stop it. But even if we're trying to stop it, they may still give her steroids. They may still give mom steroids. That's good, right? If the baby doesn't come and they're able to stop premature labor, no harm, no foul. Right? It's not going to hurt the rest of the gestation of the baby. It's not going to hurt them in the future. They don't have to be induced later on necessarily. Right? So those are all things that it's no harm, no foul. If we think that kid's going to come early, whether or not we can stop that delivery, then we'll go ahead and do the path of being conservative with it and give mom the steroids just in case to help out those babies' chances of having a better time or better development in the NICU. So prophylactic surfactant. So there's 2 types. There's prophylactic and then there is rescue. And so we'll talk about the difference between the 2. Prophylactic is given within the first 15 minutes of life. So you'll be taking surfactant with you to a delivery room. And as long as the kid's stable in the delivery room, the kid's not even 15 minutes old yet, you might be giving surfactant. This is beautiful. It's shown to decrease damage and pulmonary edema if we give it within the first 15 minutes of life. In other words, whatever surfactant they do have is optimized, and we're going to provide them with more mature surfactant as well. Less likely to have pulmonary edema, which is good because that neutralizes whatever they have. So this is a beautiful situation. You got to remember, and this is in bold for a reason, we only give surfactant after the baby is considered stable. So if we're still having to do if we're still doing chest compressions, if we're still having to push epi, we're still having to push drugs and so on and so forth, if that kid's not stable, right? If that kid doesn't have a heart rate over 100 and, at least an APGAR of like 8 or above, we're not probably going to look at doing this, or 7 above, depending on the perinatologist, the neonatologist, the NNP, so on and so forth. We've got to make sure that kid is stable before we start pouring stuff down their ET tube. I hope that makes sense to you. Before we start pouring fluids down their ET tube, kid's got to be stable, right? It's just like a PFT on an adult. If an adult is breathing at a respiratory rate of 40 and they're sweating and they're tired and they're fatigued, are you going to make them go do an MVV test? No, right? That'll tire them out even more. That's not good for their stability. It's only done when the patient is stable. And same thing here. As of recording this, we only do it when that kid is stable. So don't let me catch you in that. Rescue surfactant is done when the baby is usually less than 8 hours old, right? 1.5 hours to, about 8 hours old. Remember, a lot of these kids will honeymoon. They'll look great initially. That first 24 hours of life or even 8 hours of life, they'll look great. They may not even need to be on the vent. In that first 8 to 24 hours, they might just need CPAP. And then somehow you'll see the surfactant starts to get reabsorbed and they're not producing the mature surfactant again, and either we resurf them or we end up going back or intubating them and going on the ventilator. So don't let yourself be fooled by the honeymoon phase. You'll see that on your premature kids out there especially. So be aware of the honeymoon period. So that's why 8 hours, sometimes like, hey, this kid looks great, maybe we'll wait to surf him. And then sure enough, like 7 hours later, we need to surf. Surfactant, prophylactic surfactant has shown to decrease mortality, pneumothorax, pulmonary edema if we give it prophylactically, if we give it within that first 15 minutes, which is great. You just got to make sure that kid is stable. And then it works well. It's more common on babies that are less than 28 weeks or less than 1,000 grams. So that would be a kilogram, right? 1,000 grams is 1 kilo. We use grams in the NICU world because you might have a baby that's 560 grams, or you might have a baby that's 4,800 grams, right? That's 4.8 kilos, right? So we use grams in the NICU instead of kilograms because we have those babies that are 500 grams, right? My daughter was 625 grams, right? Very, very small babies when we're looking at it, so we like to use the grams. And then you'll see surfactant is dosed per kilo or per 1,000 grams as well on a lot of situations. Like I remember Surfanta is like 4 mLs per kilo for every dose, and CuraSurf is 2.5 mLs per kilo for the initial dose, and then 1.25 for all subsequent doses and all that stuff. But it's more common for your kids that are less than 28 weeks or less than 1,000 grams. If you're at a facility that doesn't do surfactant replacement therapy, or a facility that is uncomfortable or unable to maintain, unable to intubate this baby, they might consider CPAP. They might consider putting this kid on just CPAP as an alternative to early intubation for surfactant. In other words, instead of giving them the medicine that sort of repels and decreases surface tension, let's go ahead and just stent open the airways as much as we can until the baby produces their own surfactant from their type 2 pneumocytes. The idea there is the risk versus benefit. If a kid has a laryngeal web and they can't be intubated, well, how are you going to give them the surfactant, right? When we're looking at a lot of these different situations, CPAP is somewhat considered a reasonable alternative for early intubation when we're looking at surfactant replacement therapy. Some hospitals also might intubate, give the kid surfactant, and then extubate. almost right away to CPAP. So you got to look at things like that too. Other hospitals might intubate, give the kid surfactant, and wait a couple of hours, depending on the hospital and the protocol, usually like 6 to 8 hours, and then extubate after that, just to let the surfactant sort of work its way throughout all the lung tissue and before it would, in theory, collapse. But you gave him surfactant, so in theory it shouldn't collapse if you extubate right away. Whole different argument out there. I won't get in and pick sides there. All right, so rescue surfactant and repeat. So clinical signs of RDS, which is that respiratory distress syndrome, can be used to indicate surfactant administration. In other words, if a kid looks like they're developing RDS, which is baby ARDS, if there looks like just the etiology is different, right? You don't have adults that have immature surfactant. Right. So the etiology is different, the cause is different, but a lot of the similar things are going on, especially at a pathophysiological level. Right. So if a kid's starting to get the low lung compliance, high PF ratio, even though we don't use the PF ratio, we use what's called the oxygen index, which you should look that one up. When we're looking at this, that can indicate that this baby's starting to go downhill, their lung compliance is getting worse, their oxygenation, they're starting to require higher FiO2s, they're starting to require higher mean airway pressures, their x-rays getting more ground glassy, right? And it's going to look like ground glass even on a neonate. As we start to see those signs, just like you would with an adult with ARDS, with baby, we start to see those signs of RDS. That might be a sign to be prophylactic and preventative, and so to go ahead and indicate surfactant replacement therapy, or in this case, since it's not the first 15 minutes of life, it would be what's called rescue surfactant replacement therapy. So, or if a baby had inactivated their surfactant, let's say their PDA got really big and they developed a left to right shunt there and they got pulmonary edema. Okay, so that baby has pulmonary edema. What do you think happened to their surfactant? Well, it's inactivated, right? So we might have to give them that as well. What about if there's insufficient delivery? Like, Derek, what does that mean? Well, if you're intubating a baby in the delivery room to give surfactant replacement therapy, one of the things that could happen is you could main stem the baby for that initial delivery. So the right lung got all that surfactant, but the left lung, not so much, right? So if there's insufficient delivery, you might have to redose or redo the... So you might have to redo the procedure and just more make sure you got the tube in the right position for that redose. Make sure you get it to the other side of the lungs there. Usually you're going to redose within that first 24-48 hours. Usually second doses are common, but there's been, as far as evidence-based practice goes, there's been no evidence to support giving kids 3 or 4 doses. However, that being said, will we do it from time to time, especially if a kid's PDA opens up and they get a lot of pulmonary edema and their compliance goes down and their FiO2 requirements go up, and they've already had 2 doses. Is it plausible that we'd give them a 3rd dose? Absolutely, right? So it all depends on the scenario and the situation, and that's what we got to be careful of when we're looking at this type of stuff. Early rescue surfactant has ultimately resulted in decreased need for mechanical ventilation. In other words, the earlier we do it, the less likely they are to need mechanical ventilation, right? Decreased bronchopulmonary dysplasia, which we'll talk about in the disease chapter, decreased pneumothoraces, and then that's with the threshold of an FiO2 of 0.45. Now remember, in the NICU world, we try to get them to room air 0.21 as much as possible. If the kid gets to an FiO2 of 0.4, in adult world, that's nothing. In adult world, that's weaned to extubate, right? They're only on 40% oxygen or 0.4 oxygen. 0.4 FiO2. But in the neonate world, we get to 0.4 FiO2. That is a lot of FiO2. 40% oxygen for a neonate is a lot of oxygen. And so that's not something that we want to see. And babies are more prone to oxidative lung injuries. I'll repeat that again. Babies, especially premature babies, are more prone to oxidative lung injuries. In other words, the higher the FiO2, the more prone they are to an oxidative injury, especially when we look at things like retinopathy or prematurity, right? So if the baby's FiO2, what this is saying, if a baby's FiO2 is around 0.45, that's when they would go ahead and trigger them to, let's go ahead and give them a surfactant dose. They have high oxygen requirements, 0.45 or more, let's go ahead and give them surfactant, right? And that reduced mechanical ventilation, BPD development, pneumothoraces, right? All using a threshold of 0.45. It's pretty darn good. Redosing with RDS, so this is babies that already had developed respiratory distress syndrome, has shown to improve oxygenation. And now you might ask here, right? This is just a little spot. I've had people ask this before. If it improved oxygenation in a neonate that had something similar to ARDS, why couldn't they do this with adults? Well, they've tried that, and I think most of those studies were done in the late 80s, if I'm remembering right, and it didn't show any statistical significance there. So if you're thinking, why don't they do this with adults? They need to figure out something different, or a different way of delivering it, because it's a lot of surfactant to flood their lungs. But that's a whole separate thing. That's adult medicine. You didn't come here for adult medicine. All right. Talk to me later if you want to go more about the adult side of things and how this could actually be something they can do differently down the road. All right, so it results in improved oxygenation, decreased ventilatory requirements, so less pressure on the machine, less PEEP, less mean airway pressure, fewer pneumothoraces, especially, and this is using a threshold that's even more sensitive. It's using a threshold of 30% oxygen. So if a baby's on FiO2 0.3, and they were saying, hey, the baby's gone up to an FiO2 0.3, let's go ahead, and they have RDS, let's go ahead and give them a redose. It's been shown to help those babies as well. So it's all risk versus benefit when we're looking at this. However, there's been shown some benefits having that threshold of 0.3 to 0.45 in that area of redosing, as long as it's safe to do so and it makes sense to do so, that might be something the care team considers versus just increasing vent settings. Well, are there babies that don't respond to surfactant replacement therapy? And that's what this slide is all about. They're non-responders. So most infants with RDS will respond to therapy. In other words, if they've developed part of this respiratory distress syndrome, where all these cellular mediators are going on, they'll have that sort of pus-like development in their lungs from the cellular mediators. Just like adults with ARDS, it's pus, right? It's that cellular inflammatory response, right? That's very identical to how the lungs will respond in adult as well as in a neonate. So most of them will respond to surfactant, right? If there's a poor response, in other words, their FiO2 doesn't change, the lung compliance doesn't change, right? We don't see a big change with the baby's status after giving them surfactant. Well, it could indicate the kid might have a pneumonia. Pneumonia is this inflammation. Will surfactant reduce inflammation? No, it's not a steroid. It won't reduce inflammation. What about hypoplasia, right? The lungs aren't developed. Well, no, it won't affect that at all, especially if a kid had congenital diaphragmatic hernia, CDH, or congenital heart disease. It's not going to change those things. So if a kid does not respond to surfactant replacement therapy, it actually could rule out RDS being the primary pathophysiology, and we might then run a test to see if they're left shifted if they have a pneumonia, their white blood cells, or an X-ray, we should know if they have hypoplasia, or get an echo to look at a congenital heart defect, right, if we don't already have one. So in fact, that might actually help us in some cases. Why is this kid having a poor time oxygenating and we give them surfactant and they don't change really much? Maybe it's something like a congenital heart defect that we just didn't know about. Right. Other people, meconium aspiration syndrome babies, especially if there's a lot of obstruction in the airways and inflammation, right? This, having poop in your airways, can really cause inflammation, right? Which is like pneumonia, inflammation of the respiratory zone, right? That's what you're looking at there. Congenital diaphragmatic hernia, that's what we were talking about there. Because the CDH can cause hypoplasia, obviously, you would not get a good response there. ECMO, VV ECMO bypasses the lungs, and that's what you'd be looking at here. So you can give it, but if we're bypassing the lungs in the first place, we're not sending a lot of blood volume through the lungs. Obviously, we're bypassing it. And so this is going to have sort of where you're not going to see that. And they're going to have, we're still going to be ventilating that kid, but we're not going to have that response that we normally would. And pulmonary hemorrhaging. And this is a big thing for these neonates, is a big activator. And like I said, pulmonary edema, especially with your left to right shunts, like a PDA, or they could aspirate blood during birth if it was a traumatic birth, or the baby's undergone a trauma, or they're, guess what? I keep on putting that in there because I think it's important for you to know. They have an open PDA, a pretty open PDA. Well, Derek, how can I tell if a baby has an open PDA? And that's going to be your pre and post ductal study, right? You're going to put pulse ox on the right hand, the right upper extremity, so the right hand to the right wrist. And then you're going to put a pulse ox somewhere else. Left hand, left foot, right foot, somewhere else. If the pulse ox on the right hand has a higher percentage than the pulse ox in their foot, then they have a PDA. They have a open PDA, right? And I think I put some information about that under the resources tab, the pre and post ductal monitoring. And we'll talk about that more later as well. So that PDA, remember that hemorrhage can happen. They might have to give surfactant because their pulmonary vascular resistance is increased, right? And so if we give them surfactant, we can then cause the PVR to go down. We don't have as much negative pleural pressure for that baby to breathe, and therefore that should help reduce the pulmonary edema as well. So monitoring during the procedure. So the procedure has some risks. We just need to make sure the baby is safe through the whole thing. If anything happens during the procedure, you need to stop, just like anything else. Hey, you're doing an EKG and the patient has a massive bradycardia. Well, stop. You're doing a neb and a patient has a massive tachycardia. Well, stop. Right? Stop and stabilize the patient, right? That's something they even test you on the boards. You're doing this and then you see, run a VTAC. Stop it. Whatever you're doing, suctioning, stop it. Let them recover, okay? So same thing in the neonate world. If you're giving surfactant and the vital signs are not looking great, you're going to let the vital signs recover and let them recover overall until you can get the patient stable enough to then continue on with the procedure, or you terminate it altogether because that baby is too labile. The baby is too sick for that procedure. All right, so make sure you do that. Other things to be aware of when you're doing surfactant is make sure it's warm. You do not shake it, but make sure you roll it. You can roll it in between your hands to warm it up. If we're going to a delivery and we have some time, we're setting up and we're bringing the surfactant with us for this delivery, let's say it's like a 26-weeker, then we can have some time to pull it up, draw it up, and leave it in the open warmer, right, to get it warm underneath our open warmer, or if we're giving it in the NICU in the isolette, get it warmed up, because that can cause a pulmonary edema as well, and vagaling if we give it cold. So you want to make sure it's warm. Don't shake it, otherwise it'll be foamy and won't be able to be used. But just make sure it's warm before delivery, as you don't need it to be hot. You're not going to put it in a microwave, but just make sure it's warm. Oxygenation, make sure that if you, like I said before, cyanosis would be a late grave sign. Something severe is going on. So that's not something you'd want to see. So if you do see that, you would stop the procedure and let the patient recover, right? Airway obstruction, I talked about that before. A mucus plug could come up, and it has to me. Right, so make sure you're monitoring that. If the ET tube becomes clogged with a mucus plug, that's a bad thing, right? Take care of that clog. You can always redose the surfactant later. Take care of that clog, take care of that mucus plug, then you can redo the procedure or continue on with the procedure depending on what happened. Titration, we'll talk about this in a second here. Titration is making sure you titrate their FiO2, and if they're on pressure ventilation, their delta P, their change of pressure. A lot of times it will improve lung compliance and oxygenation together, so you might have to go down on your delta P and down on your FiO2. Just remember, when you titrate, baby steps, right? We have small babies, so do small baby steps when we're doing titrations with mechanical ventilation. A lot smaller steps. Adults, like FiO2s, usually will go by 10% at a time. Baby, when we're titrating FiO2s, but with babies, we only do 4% at a time, unless the hospital policy says different. Usually it's just small little 4% changes. When we're looking at this, the heart rate, they go into bradycardia, stop it. Make sure they recover. Make sure the ET tube's not too deep, or make sure your surfactant wasn't cold, right? Things like that. Stop it, let the baby recover. Surfactant in the ET tube, it should not be visible. If you did the procedure right, usually we'll instill it. So the baby will be supine. We'll put a catheter in the airway. We'll instill half the dose, right, for half the lungs. While the baby's supine, we'll pull the catheter out, and then we'll rotate the baby to a side. Let's just say left side first, okay? So we rotate the baby to left side down, or left side dependent, and we'll bag the baby for about 30 to 60 seconds, or we'll put the vent at a rate of 40 for 30 to 60 seconds for a while there. And so, at that point, if we gave them the right amount of surfactant, in other words, we didn't overdo the dose, right? We didn't give them too many mLs of fluid, then we should be able to see that fluid should disappear within a minute or so, right? If not earlier. And then we'll take the baby back to supine. We'll reintroduce the surfactant catheter, give them the second half of the dose, then rotate to the right side dependent, 30 to 60 seconds on that side. We'll deliver the surfactant. You shouldn't see it in the ET tube anymore. Then you put the baby back in supine. Should be done, right? So if you see surfactant coming up out of the ET tube, that's inadequate delivery. So that might either we overdose the mLs of fluid, which is not good, right? Because it's going to take a lot to overcome that. You don't want to drown the kid, right? Even if it is something good like surfactant. But that also indicates inadequate delivery, and there's issues with that as well. Ventilator changes, stay in the room. You're not just going to give them the surfactant and then walk out of the room. So plan to stay in there. Titration of 502 is usually almost done immediately. I'm being as honest as I can with you guys. You'll be in that room, and that baby will have their saturation will start going up and up and up and up, right? They'll be at 97% in no time as that surfactant starts to work its way around their lung tissue. So you'll have to titrate almost right away. So remember, baby steps, don't overdo it. Don't just take them from, 30% to 21%, right? Just start doing that like little 4% change in the FiO2, right? Delta P, if they're on pressure control ventilation, which is delta P is the change of pressure. So like 20/5, right? So when a kid gets surfactant, they might be able to go down to like 15/5. So that delta P might change to 10 versus 15, right? That delta P might be able to change because if you left them on this 20/5, that could then cause hyperinflation, right? Volutrauma, barotrauma, and cause that kid to get worse. So you just need to be aware of that. All right, the first breath. This is a very important slide for a lot of reasons. So baby's first breath, when we're looking at the first breath in utero, fetal breathing is not necessary. In other words, it's not necessary to maintain life in utero. Now, it does help with developing their lung muscles and moving amniotic fluid and so on and so forth, but it's not necessary for them to sustain life in utero. That's where they steal it from mom, right? They steal it through the umbilical and the placenta. So when the baby is born and cut off from the placenta, now they have to breathe on their own. So now they're dependent upon their own lung system to provide oxygen and to get rid of CO2. And so this is where that first breath can be very important, especially if there's retained fetal lung fluid like we see in some C-sections. Things like that can really affect or impact that kid's ability to establish that FRC. And the first breath is what primarily establishes the functional residual capacity of that baby. And once they develop that, then all their next subsequent breaths will just be like tidal volume breath, right? So the first one is going to be more like a vital capacity breath to help establish like a TLC breath, right? Really super deep breath to help establish their TLC so they can get an RV, so that way their tidal volumes can be normal. Oh, lung functions. So when we're looking at the first breath, how is it initiated? Well, there's three things. There's chemoreceptors These are the ones that look at pH, right? Your central and peripheral chemoreceptors. Your central chemoreceptors look at pretty much pH, which is a subsidiary of CO2 levels, right? So it looks at pH, and your peripheral chemoreceptors look at PO2. And it's that PO2 that usually then causes your shunts to close, your PDA especially to close. Thoracic compression is another way. That recoil, once they go through the vaginal canal, and then once that baby's thoracic cage comes out of mom, that thoracic compression will squeeze the baby's chest like a chest compression, and then as they come out of mom, the thoracic cage will expand. So that draws in that air that causes that big breath. Well, this is one of the things that we look at, that big breath that happens after the thoracic compression, right? When the thoracic cage is released after the baby comes out of mom. That release, that big negative pressure, helps pull blood and decrease PVR, decrease pulmonary vascular resistance big time, because we're expanding lung tissue. So it'll decrease PVR and it'll help transition that PDA. It'll help overcome and cause a good TLC breath. It'll help establish that FRC. It'll help with remove that fetal lung fluid to the vascularity and to the lymph tissue. But if we don't have that, like let's say at a C-section where we don't get the thoracic compression, that's where we might have more issues. That's why C-sections might be considered more, they're considered a risk delivery, even though they're very, as far as things go, we're not usually too concerned, but some babies might have an issue with this. Stimulation, the environment in the uterovis hospital. You go from pretty much a hot tub. The way I used to explain this when I would orient students, you go from a warm, dark, moist, obviously, environment to now a dry, cold, light-filled environment. It's a whole different stimulation, right? A whole different stimulation. So it's that extra stimulation or that stress response from the external environment that also helps transition that breath, that helps them take that big breath. Oh, I'm in a different place. I'm no longer in my whirlpool. What is going on? All right, the pressure. So when we're looking at these babies, when they're born, to overcome the completely closed alveoli, they have to generate a lot of force. 60 to 80 centimeters of water pressure, right? Go put a patient on a peak pressure of 60 to 80 centimeters of water pressure. You will blow up their lungs, right? That's a lot of pressure, right? So don't do that, right? So they have to overcome a lot of negative pressure here, 60 to 80 centimeters of water pressure, just for that first breath because of the surface tension. That's a lot of pressure. That's why they need the thoracic recoil, right? That squeeze and recoil. That's why they need the stimuli. That's why they need those three ways of doing that, because it's going to help them get that first breath. That first breath on a term baby should approximately be about 40 mLs, and that's more like a TLC, right? That's a vital capacity breath. So they'll take that deep breath in, which then establishes their FRC. Right, so 20 to 30 mLs, or most of it, will remain in there for FRC. So their tidal volume would only be like 10 mLs then, right? When we're looking at this perfectly healthy term baby, which, why are you at that delivery if the kid's perfectly healthy in term, unless it's someone you know? Why are you there? So we'll talk about that later. But when we're looking at this, I would pay attention to this. This is something I would put in your notes. That first breath is going to be big to establish that FRC, and then they're going to have small tidal volume breaths after that. So it's important that that first breath take place. The whole thing here is we need to reduce this, and that surfactant helps overcome that pressure and prevent them from closing after that first breath. So if that baby starts out with surfactant deficiency or diluted surfactant, that's going to be a big issue. All right, so what are some applications of surfactant replacement? Well, if the kid's less than 35 weeks, something to consider. Does it mean they have to get it? Absolutely not. All right, we had 28-week babies that were born in our NICU that never required, we did not surf them. They did great coming out. We're just monitoring them for obviously blood sugars, feeding, temperature control. Obviously, those babies can't control their own temperatures yet. So a lot of other things obviously with those babies, but they never really required us to give them surfactant. So you might have a 28-weeker, doesn't really need anything, especially if mom was given steroids, things like that. So if the kid's less than 35 weeks, we consider it. Doesn't mean that we do it. Okay, so treatment, if it decreases the incidence of pneumothoraces and deaths, that's something that we might want to consider. If this kid is trending in a bad place, or if the kid is at a risk for pneumothorax, maybe we want to consider giving them surfactant. Multiple signs and symptoms of RDS, that's a good thing to consider. Natural versus synthetic, there's not one that I'm aware of that's been proven statistically significant better over the other. Okay, so it's important you hear that. There's a synthetic there's synthetic surfactant on the market, and then there's ones that are made from other things like bovine and porcine. Like Curosurf is from porcine, and that's why it's protractorant alpha, and that's made from porcine, so from pigs. And the big thing with that one is it's a natural one, but compared to, I think, Surfactant, no, one of the other ones that's a synthetic, it's only like a 3% difference in the ability to titrate different settings. Like, it's a non-statistically significant difference between the two. So different hospitals will carry different types of surfactant. So you'll be sort of bound to whatever your hospital carries. You won't exactly have your choice here. So they might just carry one type of surfactant, like only Curosurf or only Surfactant or only so on and so forth. Infosurf or whatever it is, right? So they might carry only one type. Just make sure that you know that there's no statistical significance, even though the drug reps will want you to know that they believe there is. As far as all the evidence out there, as of recording this, there's no significant change in how healthy a baby is with one over the other. Am I biased towards one of these? Absolutely. It's the one we use the most, and I can give you many reasons of why I loved that drug, that version of surfactant, but that's not something that I'm going to put here. There are people that also might, babies that are non-responders in other areas. We talked about that before here, but if they have deficiency, dysplasia, or antitrypsin protease deficiency, they also might be non-responders as well. I would not worry about that category. I just put this in here for your completeness of knowledge. So I wouldn't worry about memorizing this category. Usually they'll undergo testing further on down the road to find out that those things could be the issue. All right, application of replacement, pulmonary hemorrhage especially. That's something that we got to worry about. So left to right shunt would be your big one here, causing a pulmonary hemorrhage, or if their PVR increased dramatically, that could also be an issue as well. That could cause them to go into pulmonary hemorrhage, like pushing epinephrine. Epinephrine can cause pulmonary hemorrhage, right? You're increasing your PVR and therefore requiring more negative pressure into the alveoli. Meconium aspiration syndrome easily can deactivate the surfactant. So the meconium aspiration syndrome, you're putting a very alkaline solution, right? Poop, right? You're putting a very alkaline material into the lungs, and that can cause a surfactant replacement. It causes that a chemical change in the surfactant. When we're looking at pneumonia or sepsis, that can easily cause a baby not to produce surfactant as well, right? Especially if they're on higher FiO2s. So when we're looking at sepsis, which is the #1 cause for adult or acute respiratory distress syndrome in the adult population, even though we're looking at pneumonias being non-responders traditionally to it, but their body's going to stop also producing surfactant because it's working on something else. And so they might need it, even though it might not change their compliance too much because they have inflammation process going on. They might still need it because their body's not producing the surfactant, so it might help reduce further lung trauma for that patient. CDH especially, they're only working on one lung, so we need to make sure that they're not going through shearing trauma as well. So that could be something that we might go ahead and give those babies. All right, so you'll go over this. This is from your reading material, and this is where you're looking at the interstitium and the alveoli. And the capillaries and how much more open those areas are, and then as we have the hyaline membrane change and it forms the thick AC membrane, and your alveoli become started collapsed over here. You see all these collapsed alveoli. It makes things harder and harder, right? And you're going to still see that ground glass appearance on their x-rays when we're looking at these things. So you're still going to see a lot of issues. Go over this in your book. We'll not spend a lot of time on this x-ray here. I have a whole separate lecture on the neonate x-rays and diseases. All right, so make sure you go through your chapters. Chapter 14 is what's in your book on this one. And just make sure you're ready to go. Make sure you're thinking about how to do a surfactant procedure. Look up some videos on surfactant replacement. Sort of get yourself comfortable with that. I want you guys to also think about doing this when we start doing labs, is practicing surfactant replacement as well.